Dr. Nipun Lamba. I am Assistant Professor in Department of Pain and Palliative Medicine in Mahatma Gandhi Medical College and Hospital, Jaipur. And today we are holding a very important session which has encountered with all of us. It has affected all of us, And we have very two distinguished guests with us. Honorary Dr. Sudhir Bhandari sir has agreed to grace the occasion to us, and Dr. Ankit Bansal sir, two very prominent people. Our session is on palliative care in COVID. And I would like to formally introduce Dr. Sudhir sir, although everybody knows sir. Sir is Senior Professor in Department of Medicine. Dr. Sudhir Bhandari sir is Principal and Controller in SMS Medical College and Associated Hospitals. Sir is also a working Vice Chancellor for Rajasthan University of Health Sciences. Sir has done his fellowship in Royal College of Physicians from London. He is fellow of College of Endocrinology, and he is associate editor of Journal of Diabetes. And he is also honorary physician to the Health Minister of Rajasthan. Sir has also written many books, many chapters, many journals, and he has also received many international awards, like World Icon Award at Bangkok, and also he's appraised by Prime Minister for Pulse Polio Program. Sir has also received various national awards, and he's actively working towards the welfare of society. And he's also running a charitable medical trust for the benefit of people. So many welcome you to sir. A very humble welcome to you, sir, Dr. Sudhir Bhandari, sir. And our second guest is Dr. Ankit Bansal, sir. He is a consultant in pulmonology and critical care in Fortis Hospital. He is an IACCM teacher, and he's a core committee member for National Conference of Neurosurgery. He is state head, Chest Council of India. He has worked in many workshops. He has received also many national awards, and he's a part of reputed international and international societies in the field of pulmonary medicine and critical care. Now, I would like to request Dr. Ankit Bansal, sir, to please introduce our speakers.
So, okay. I first invite Dr. Seema Rajesh Rao. She is presently designated as Associate Director, Education and Research, and presently she is there with Bangalore Hospice Trust, Karushnaraya. She has 20 years rich experience in psychiatry with 10 years in palliative medicine. Her area of interest is psycho-spiritual care, ICU palliative care, and dignity therapy. Our major achievements is APHN Palliative Care Consultation for Dean, Collaboration for Palliative Care Singapore, with Honorary Tutor in School of Medicine, Cardiff. She has multiple honors under her name. She is member of Quality and Clinical Advisory Board, Palcare, Mumbai. She is also a national faculty in Indian Association of Palliative Care, course chair for certificate course in psychology in palliative care in Indian Association of Palliative Care. She is also a Central Council member, Indian Association of Palliative Care. So I invite Dr. Seema Rajesh Rao for her lecture. Kritika Rao. She is presently designated Assistant Professor in Department of Palliative Medicine and Supportive Care, Kasturba Medical College, Manipal, Mahe, Manipal. She has area of interest in pediatric palliative care, ICU palliative care, neuro palliative care. Her major achievements is lead pediatric palliative care service, KH Manipal, EPC matter facilitator, member of Cancer Quality Initiative Committee, KH Manipal, faculty for IAPC Academy, IAP PPC course. She has many publications under her name. So I also welcome Dr. Kritika Rao. I introduce Dr. Shweta Priyar. She is Professor, Kasturba Medical College, Manipal, Manipal Academy of Higher Education and Manipal. She has a very rich experience of more than 17 years Her area of interest is sepsis and difficult airways. She has 23 publications in national and international journals. I also invite Dr. Vishal Shanbag. She is Assistant Professor Critical Care in Kasturba Medical College, Mahe, Manipal. He had 12 years of experience with area interest in infectious disease, ARDS, mechanical ventilation, hemodynamic monitoring, and palliative care in ICU. His major achievements: he is editorial board, Indian Journal of Respiratory Care, mentor for critical care nursing practitioner training courses, research guide, and member of COVID expert committee KH, and he has many publications which is both international and Indian under his name. I also introduce Dr. Pankaj Singhai. He is Assistant Professor, Department of Palliative Medicine and Supportive Care, Kasturba Medical College, Manipal, the Manipal Academy of Higher Education. He has a rich experience of more than 7 years with the area of interest in integrative palliative care, renal supportive care. His major achievement is Bruce Davis Gold Medal Award, IAPCON International Travel Scholar, MACC Travel Grant, lead author, renal supportive care, and supplement in IGPC. So I invite all the esteemed faculty for the distinguished session. Hello. Yes.
Thank you so much, Vansal, for the wonderful introduction. And I would like to begin this session I just want to mention that the pandemic brought about such a humanitarian crisis, and wherein palliative care was recognized. This session is about introducing the COVID-19 palliative care and end-of-life care plan pathway. Dr. Seema Rao Madam would give us an introduction towards the same. Thank you.
Good afternoon to one and all. We are into the third year of the global pandemic. Each country, each region has experienced and managed this crisis differently. What is common is the unprecedented suffering this pandemic has caused. Time and again, the role of palliative care in mitigating suffering in humanitarian crises like this has been emphasized. However, integration has often been patchy, and many critically ill COVID patients lack access to quality palliative care. Kasturba Medical College and Hospital is a 2,000-bedded university teaching hospital in the temple town of Udupi in southern India. It is the designated referral center for critically ill COVID patients in the district. The hospital has had about 3,479 admissions and 552 COVID-related deaths till date. During the first wave in 2020, the hospital, like the rest of India, was working under crisis standards of care. Over 47% of inpatient hospital admissions needed ICU care. The mortality rate was about 16%. Decisions had to be made for fair allocation of resources. While the fundamental ethical principles still were relevant, we had to shift focus from caring for the individual to caring for the society as a whole. Certain trade-offs were necessary and imperative. Active avoidance of wasteful care took precedence at this point. As the pandemic unfolded, the need for palliative care became evident to all healthcare providers in the hospital. An expert team was constituted to develop a palliative and end-of-life care plan for critically ill COVID-19 patients. This interdisciplinary team of doctors, nurses, administrators, and members of the ethics committee deliberated on creating a process for palliative care referral and a pathway for palliative care service delivery. This process was aided by the presence of a well-established specialist palliative care unit, which took the leadership role in creating the care plan. The hospital had a well-integrated ICU palliative care service since 2019. Few of the ICU physicians were trained in palliative care. There was also a well-accepted end-of-life care framework, which was already being implemented in the ICUs as well as in the wards. The hospital also had a well-stocked pharmacy where essential medications were available easily and accessible at all times. All this aided in the provision of palliative care in our setting. What was, however, needed was a triage system for early identification of patients who needed palliative care. We all could use. We needed a communication framework for discussing and documenting preferences regarding limited life-sustaining treatment, and a pathway for providing psychospiritual and social support for patients and families who were ravaged by this pandemic. In addition, what the hospital administration offered us was a 7-bedded COVID unit, which was set up so that patients could receive quality end-of-life care. The screening checklist that was developed for triaging patients was adapted from national and international recommendations. It provided the non-palliative care clinicians with a blueprint for identifying palliative care needs in the COVID-19 patients. It looked at 5 parameters: the advanced age, presence of comorbidities, evidence of frailty, presence of advanced those who would need palliative and end-of-life care. It was quick and easy to use in the busy COVID wards and was easily adapted by the primary care teams. In crisis situation, often information sharing is fragmented and asynchronous, especially when transitions occur. The palliative care referral checklist attempted to make this process of transition seamless and comfortable. The referrals were documented in a structured manner in this checklist. Patients were identified for palliative care. Care was ensured to achieve medical consensus. All care providers, including the doctors, nurses, the counselors, were informed about the palliative care referral. The medical decisions were communicated to the family before the referrals to palliative care were made, and these discussions were clearly documented in this checklist. As I mentioned before, the hospital already had a framework for recognizing, communicating, and documenting medically futile intervention. This stood us in good stead during this trying times. This was a 4-step process. The first step involved documentation of futility by 2 treating physicians. The second step involved communicating the futility to the patient and the families, which was done by the critical care team or the primary treating teams. The third step involved documenting patient and family preferences regarding end-of-life care, which was done jointly by the palliative care and the primary treating team. The final step or the 4th step involved ratification of this decision by the hospital ethics committee. As burdensome as this process may seem, we were able to adapt to the changing scenario and ensure that these were completed within 24 to 48 hours. We did this by appointing a single point of contact for referrals between the treating unit and the palliative care team. The members of the ethics committee were available round the clock for the ratification process, and virtual meetings between the team members as well as between the patients and the healthcare providers ensured quick decisions were made. We know that resources like PPE had to be used very judiciously. The palliative care teams were considered non-essential and had limited access to these resources and also to the critically ill patients. We had to rapidly educate and empower the non-palliative care physicians in managing symptoms like delirium, dyspnea, agitation, etc. Printed handouts were posted and circulated in the COVID-19 wards and ICUs for easy reference of the non-palliative care physicians, which had clear indications for starting medications, the drugs, and their dosages clearly written. Palliative care teams had to be flexible and responsive to and rapidly adapt to the changing circumstances. Much of the communication moved to the virtual domain, be it intradepartmental, interdepartmental, and between healthcare providers, patients, and families. This was something that we had to learn anew and adapt to very fast. Psycho-socio-spiritual support was provided entirely virtually, as it was very difficult to access family members who themselves were in quarantine. It fell on the palliative care teams to ensure patient and caregiver remained connected. And we succeeded in achieving this again through virtually, through WhatsApp and telephone calls. We had to be proactive and innovative in the ever-changing scenario of COVID-19. We audited the outcome of the COPE-CP plan in October 2020. 10% of the patients who died who were admitted to the ICU were referred for palliative care. Majority were over the age of 68 years and had multiple comorbidities and had critical COVID-19 illness. In 96% of these patients, discussed and documented, but implemented in only 53%. All received active medical management for COVID-19 and adequate symptom control at end of life. To conclude, the pandemic has brought a paradigm shift in attitude towards palliative and end-of-life care. COPE-CP, or the COVID-19 Palliative and End-of-Life Care Plan, ensured that critically ill COVID patients were able to access and receive quality end-of-life care. Compassionate and collaborative care should be the norm rather than an exception, and that is what this pandemic has taught us. Thank you. Now I will hand over the discussion over to my colleagues to take it forward. Thank you.
Hello, everybody. I am Dr. Kritika, Assistant Professor at KMC Manipal in the Department of Palliative Medicine and Supportive Care. Along with me, from the team of KMC Manipal, joined by Dr. Shweta Priya Rao, Professor, Department of Critical Care Medicine at KMC Manipal, Dr. Vishal Shanbag, Assistant Professor from the Department of Critical Care Medicine, KMC Manipal, and Dr. Pankaj Singhai, Assistant Professor in Department of Palliative Medicine and Supportive Care, KMC Manipal. We bring to you our experience in providing palliative care in severe COVID-19 illness. Dr. Seema Rao Madam gave a wonderful lecture where she took us through how we developed the COPE CP plan, and we would like to share our experience based after the implementation of such a plan. Through this discussion, we'll take you through the case scenarios. Pertinently, we brought those two scenarios to the audience here because they came up with its own challenges, and how did we adapt to those challenges, and in the end provided a good care plan for these patients. So to take this topic ahead, our first scenario for today is an 89-year-old lady. She's a known case of diabetes mellitus, hypertension. She also had a history of carcinoma endometrium, diagnosed 10 years back, status post surgery. On the day 7 of her illness, she was admitted to a local hospital where the RT-PCR was positive for COVID-19. Then she was treated with remdesivir and steroids as per the government laid down protocols for 8 days, from day 8 to day 16. However, on day 16, the doctors noted that she had worsening of hypoxia and she required increasing supports of oxygen up to 15 liters per minute by NRBM. The HRCT chest severity score showed 17 on 25. And hence, from there, because it was a local hospital, family decided to refer her to a higher center for further management and ICU care. She was received on our hospital on day 16, and a repeat RT-PCR again came positive. Now, being on this case scenario, I would like to ask Dr. Vishal Shanbag, sir. So, with regarding to this patient, what were the challenges that you faced while managing this patient?
As you mentioned or summarized in your previous slide, this patient had an advanced age, previous malignancy, post-operative status, and now she is already 2 weeks of COVID-19 and now presenting with worsening of hypoxemia. So it's clearly an ARDS worsening and then requiring a higher support. But patient was conscious, blood pressure was stable. So far only lung involvement was there, but other organ systems were stable. And currently she required HFNC or NIV to maintain her oxygenation. Patient was not able to meet the family for a long time. Like already 1 week back, she was admitted in isolation. And again, repeat RT-PCR also was positive. So again, as per the protocol during the last year, she was supposed to continue isolation till the COVID becomes negative, or at 18 days. So she was unable to meet the family and going through a lot in the ICU. And now she is going for escalation of care. So she wishes to see the family members more often than the ICU restrictions. She knows that she is having COVID-19, but she has a strong willpower to leave, and she hoped to attend the wedding of a granddaughter in coming 3 months. So as per the family is concerned, the daughter was staying with the patient. She also was aware of the situation, and other children were staying abroad. As I mentioned before, they had a family function, and the patient expressed a desire to see the marriage of the granddaughter. But at the same time, she had clearly expressed the wish that she should never be put on a ventilator. So the family also did not want to go against the wish of the patient. So as far as the physician is concerned, we have certain factors to consider. So one is how far the family can support the patient. So here the family had no financial constraint, ready to support till whatever extent is possible. And this patient also was kind of VIP, so I used to receive a lot of calls, lot of pressure to do everything possible for the patient, and anything needed was about to be available. So the dilemma about the current situation is whether the patient is having a worsening of her COVID-19 itself, like cytokine storm, or is there a new secondary infection that is causing the worsening of oxygenation? Because her markers were high, but she was unable to produce any sputum to test for any infection. So we were unable to prove or disprove infection at this point of time. But if it is worsening of the ARDS because of COVID-19, the option was to give immunotherapy, like tocilizumab. But tocilizumab, as we all know, it's an immunosuppressive therapy, and there is a risk of worsening of infection if the patient was having infection, and also deterioration of clinical condition, and which obviously will result in a bad outcome in a patient like this. So we had a dilemma whether to convince the family about the prognosis and then go ahead with the ventilator if required, or should we consider immunosuppressive therapy, Or we also had thought about palliative, of course, because when we go through a checklist, we had certain indicators to say that this patient may be for palliation. So we had initiated a discussion with our palliative team.
Thank you, sir. That was quite an extensive challenges you were facing with, and also there was another aspect of patient's autonomy that we could come up with here, where the patient expressed her desire as to what she wanted and did not want to get done. So when you considered her, sir, for palliative care referral, what was the criteria that you looked at when you looked at her decision making, mainly for a referral to the palliative care team?
It was mainly the age factor. She has previous malignancy, and now she's in the 3rd week of illness and still requiring a ventilator. So again, it was expected that she may require to be on ventilator for more than 4 to 6 weeks, which at her age would definitely have a bad outcome, because she may have secondary infections, or her ICU stay itself may be complicated by multiple things. And that's the reason we initiated the consultation with the palliative.
Okay. So as per our COPE CP checklist, she fulfilled those criteria which required for it. That was, so we went
and
by
most importantly, the patient autonomy also was kept in mind, because she has clearly expressed that she should never be on a ventilator. So that was the first priority, and then we looked at other factors which also were fitting into referral to palliative.
Quite right, sir. So Dr. Pankaj Singhai, when this case was referred to your team, how did you go about discussing with the family?
Yeah, so when after we met the futility criteria that these patients may not improve with very aggressive supports, and as Dr. Vishal told, like the patient had very clearly told that she doesn't want to be on ventilator and all, and if that scenario comes, she will opt for a comfort care in that case. So there were very clear direction from the patient, and also from the treating unit also there was a consensus about the futility. So we arranged a joint family meeting with all responsible family members were called either virtually, and they were called for a counseling group, and we sat together with treating team, with the ICU physician and palliative care physician there. We elaborated what all goals are there. We discussed the options of withholding from the ventilator or cardiopulmonary resuscitation in case of worsening. But at the same time, we also ensured that we will give the optimum care what is required, with main focus on her comfort. But also we ensured that whatever longevity we can give, we will try those treatments. So in that family discussion, all the plan of care we discussed with the family, pros and cons. So in that family meeting, we were able to clearly document what we want and what we don't want in that case.
Right. Thank you, Dr. Pankaj. So that was very much that in a joint family meeting helped you to come up with a plan of care, but at the same time, the plan involved that you hoped for the best, but also planned for the worst in case what happened. It was very succinct and a very tight, in a very discussion went around very well as what you said. So Dr. Vishal, sir, what was the final outcome that happened after such a family discussion?
Yeah, as I mentioned before, we did a joint family discussion, but when we started the discussion, the patient had only lung problem. There was no other system involvement. Patient was fully conscious. So the family also, were requesting that we can go for a futility in case she worsens from this stage to a level of getting an intubation or ventilator. But at the given point of time, they wanted to continue whatever essential treatment is required, including the immunotherapy. Okay, so that's the reason what we decided is after the meeting, we had decided on a time-limited trial. We kept a time of 1 week of aggressive therapy of whatever it is required, including the immunotherapy or antibiotic or inotrope support. But if at any point of time she worsens to a stage where she requires an intubation for a ventilator, or if she has organ failure requiring dialysis or life support, At that point of time, we thought we will not escalate to next level. So we decided that we will go for immunotherapy. So we gave first dose of immunotherapy on the second day of admission. And then we waited for 2 days. And then the second dose also was received. And after 4 days, the patient started showing improvement in oxygenation, because initial 2 to 3 days, usually we don't see improvement in oxygenation. So the family was very anxious, like what happened, we are given the injection now, what happened next day. So we were explaining them every day what is happening and what is the expected outcome. So they were very clear about the day-to-day affairs. So on day 4 onwards, the patient started showing slowly improvement in oxygenation. So from HFNC, we were able to go back to a Venturi mask and then to a nasal cannula after 5 days. But fortunately, the patient did not end up in a secondary infection, nor she worsened and required a ventilator. But at the same time, we were able to give the essential care, which was immunotherapy at that point of time. So it worked for her after a few days, but definitely the decision was worth discussion. She developed few complications, like she had multiple hematomas, she had drop in hemoglobin requiring transfusion, but most of those were done because it was essential for her. And she was taken to another ward after some days when the oxygen requirement came down to nasal cannula. And we also made sure that the daughter stays with the family once they go out of ICU. And she was tested negative subsequently. And she stayed in the hospital almost for a total of around 40 days, where she was off oxygen. And then she was discharged home. And she did not fortunately develop any secondary infections or any complications of organ failure. And subsequently, she went home. She attended her granddaughter's wedding after 4 months. And till now, she's still alive. She's conscious. She's eating orally, doing all her works, but with support and with limited mobility. She's most of the time restricted to bed. The family also are very happy with the decision which we made together. And they were grateful about the efforts taken by our team and joint discussion, what decisions we made, daily updates we are given to the patient. And also they were happy that we kept the word that we did not put on ventilator. So even though this lady was a very old lady, she had malignancy, and at a given point of time when she was referred to her, nothing was going in her favor. But still, with a good discussion, with good communication, we were able to meet the required points and also give her essential care. But at the same time, we also agreed that we will not go to next level of escalation. So that's how probably we expected this patient will not do well, but she still did well. So she's alive still after 2 years from the particular event, and still she's doing well.
So that's like dual goals of care we had, and we had a very clear discussion, like what if things goes wrong, but at the same time we could offer good treatment that helped. So yeah, thank you.
Right. Quite right. Thank you so much, Dr. Vishal Shanbag and Dr. Pankaj Singhai, for that wonderful discussion around this case. I would like to move on to the next case for today. Next case for today is a 30-year-old female. She was gravida 2 para 1 and she was at 35 weeks plus of gestation. She presented to the hospital with shortness of breath and cough since 1 day duration. On presentation, vitals showed that she was on 60% Venturi with a saturation of around 80%, tachypnea, and she was tested for COVID-19 with RT-PCR coming positive for same. Due to these issues, she underwent an emergency LSCS and immediately shifted to the ICU, and she continued to be requiring the ventilator support. However, over the few days, she was given appropriate management and treatment for COVID-19 illness. Same time, she was pruned 3 times. However, she was status quo. Hence, the family was offered ECMO and it was initiated. Along with that, she also developed sepsis, eventually to MODS. So, Madam, Dr. Shweta Priya Madam Rao, ma'am, in this case that you had seen in the ICU, what are the challenges particularly that you came across as a physician there in the ICU treating this patient?
The biggest challenge here, Kritika, was that we had a young patient with us who was a mother of 2 kids with very severe ARDS. So we wanted to do everything possible to try and save this patient. So when she came to us, because her oxygenation was very poor, we immediately proned her. But then she did not improve much with proning. So family was asking us what else could be done for this patient. We offered ECMO and they immediately decided to go ahead with ECMO. But our center routinely doesn't manage patients who are on ECMO. We have very limited experience with managing patients who are requiring ECMO. So we were not too keen on offering it, but since there was no other choice, we decided to go ahead with ECMO. The other problem we faced here was that when the patient tested positive, at the same time her husband also tested positive for COVID. So he was not available for any of the meetings that we had with the patient party. So finally we were talking only to the brother of the patient and the brother-in-law. So only few times we could talk to the husband over the phone, and whatever we had to convey, we had to inform him over the phone. So this was another issue that we faced when we were counseling the patient party, because we had multiple meetings with the patient party. From the beginning, they understood that the chance of recovery was very minimal because she had a very bad ARDS and she was not responding to the usual treatment, but they were not ready to give up.
Right. It can be very difficult for them with this scenario. I mean, a young female,
patient,
just delivered recently. All of that could be very emotionally challenging for the family members to accept the situation that she was in. So, madam, how did we come around decision making when we referred this patient to palliative care? What were the things that you looked at?
When she first came to ICU, she was not fitting into any of the criteria for referral to palliative care, the COPE-PC protocol. But over a period of time, she developed various complications, and finally she ended up having sepsis with septic shock and multi-organ dysfunction syndrome. And she was not responding to any of the treatment modalities that we were offering. So that's when we decided that the chance of recovery is now going to be minimal, and we went by the Blue Maple protocol that we usually follow for our ICU patients who have minimal chance of recovery, and we involved the palliative care team also.
So that was like we had to look at both aspects, not only COVID also, but also COVID, the ICU critical illness part too, when we took this decision to refer to palliative care. Dr. Pankaj Singhai, how was your discussions that when this patient was referred, how did you proceed with discussing with the family?
So as Dr. Shweta Priya ma'am said that it was a quite difficult situation because we had a young woman who just delivered a baby. His family members were also COVID positive, and patient was in a very serious condition. So everyone in the family was very distressed. But as we had a protocol in our ICU that always we used to have a joint family meeting. So we called all involved physicians, gynecologists, critical care physicians, and also palliative care were also integrated once we got to know that her condition is quite serious. So here we involved all the family members, his brothers, his husband was there over the phone in all family meetings. So we ensured that we will involve each and everyone who is involved in care of the patients. Also, once after a week time, his husband improved, and also he could also come. So what we ensured that over the time, like we could have multiple family meetings, so we can give a time limited trial to see if there is any chances of improvement. But once things were progressing and patient's condition was deteriorating, we told them about the fact that she may not improve, and this was very sensitively we told family members. But it took some time for us also to give this information and for the family, because it was very difficult for them. But over the time they understood condition, and at the end they understood that she may not come out of it. That time they signed for not to resuscitate or not to she was already on quite maximum support, but they said like not to resuscitate if she is not going to come out. So what we felt like having joint family meetings so that a single message goes to uniform message goes to the family members. There is no different kind of message goes, and among family also they were discussing. It's not like there was no collusion among the family members. So those things help family members to understand and then finally coming to a conclusion. Yes, we thought we will have further family meetings after this thing.
That was quite challenging, overall a period of days, multiple family meetings, being every time empathetically communicating with the family members, also understanding how sensitive the issue is with a young woman that we are discussing. There was a concern about maternal mortality here. So these all can be very challenging situations. Dr. Shweta Priya Madam, once we had this discussion, what was the final outcome with this patient? How did we proceed further?
Once we referred this patient to palliative care, it took almost 10 days for them to decide about not escalating the care further. So they had some doctors in the family and some other doctors known to them. So they discussed with all those people, and finally they also told them that the chance of recovery in this case is very minimal, very remote. So that's when they finally decided to go for no further escalation of care. And they wanted another 48 hours time to decide about withdrawal of life-sustaining support. So then we got them, got their signatures on the papers, and just before 48 hours could be completed, the patient had a cardiac arrest, and she passed away. We did not give CPR because the family had already agreed for no further escalation of care. So this is how finally she passed away.
At least this way we were able to achieve with the family's distress was there, and this way we the discussions that we had over the past 10 days, family gradually came to acceptance where they could understand the situation and take some steps enough to ensure that she does not suffer for long. And we're really sorry with the state of affairs that happened, but for the audience I would like to bring up this issue that this was not a single, there were so many such cases that we saw. There were, hundreds referred to palliative care. Due to time limited situation here, we had only chance to discuss these two with you. But there were many referred, and not only for end of life care, wherein sometimes we had cases for anticipatory just goals of care discussion that which fulfill the checklist criteria, but still patient showed improvement after continuing treatment and was discharged to home, or there was somebody who was discharged to ward area with or was on minimal supports, and then probably was after repeat testing as per the guidelines made by the government was negative or shifted out, and then further discussions were continued. So it was not always that like how we saw in case one where a single family meeting and outcome was decided, and in the second case where we required multiple such family meetings. So at the end of this, our outcomes that we had when this COPE CP was in place, there was a noticeable difference in the attitude. There was a paradigm shift in the attitude of clinicians, where there was an acceptability of the palliative care approach in itself. There was more willingness to try to triage early, to ascertain futility, and on basis of that, have an open communication with family members about prognosis, letting them know what exactly is happening. That was a major shift in practice. Another thing that ensured is a lot of patients who were suffering with a high symptom burden, they got adequate symptom control at end of life. And this also helped in reducing the suffering for the patient and the family members. Because being isolated, the patient being in quarantine in the hospital, in the ward area, family members are not able to see. Just through a video phone call, they were having conversations. At least the satisfaction that the patient is not suffering through, let the family to feel better with that, and be having a trust in the team that was involved in the care of their family member. These discussions that we saw were primarily led by the primary care team. I mean, we have our ICU physicians here who are part of it. It started from them. They were the ones who were identifying patients, triaging them, and communicating it to the palliative care team. And then that's how the discussions went on further. For us, palliative care teams over the second wave, we were more involved with difficult negotiations and goals of care where there was more of denial, there was collusion, family were in anger. We saw that the family was bargaining in this case that we discussed for over 10 days period. So there was that need that, the palliative care approach was slowly taken over by the primary care team, where we came in and we gave our specialist input later on. So I would like to bring up this topic further open for discussions and questions from the audience. Thank you.
Thank you.
There is a question in the audience. It's about when this pathway was proposed, was there any administration resistance? I would direct this question to Dr. Seema about how was her experience in trying to implement this.
Thank you, Kritika. In fact, if you had seen the presentation, when the administrative team from the hospital also very much were part of the COPE CP. They were actively participated in drawing up the plan, and we had full support from the administration. So as such, we did not face major resistance. In fact, they were part of the whole process. And I think that having very good end-of-life care policy enabled, all stakeholders to come on the same page and helped us implement this plan. Thank you.
Thank you, Dr. Seema Rao. Well, there's another question. How easy or difficult was it to talk to families from a perspective of a critical care physician? I don't know, sir, anyone would want to?
Yeah, it was challenging because we had two issues. One is the patient was most of the times on ventilator or NIV, difficult to communicate. It's the representative who was talking to us many times. And also because of the restrictions of infection control, direct communication also was very difficult. So many times we used to do a video call and then call them for a final meeting. It was really difficult for us to talk to them directly, but we made use of technology. And in the first year, if everyone remembers, people are telling there's no COVID, so people were still doubting that something like this could happen to somebody who was healthy before. I still remember we had a 20-year-old boy who had severe COVID, and I was getting multiple phones that he is somebody who's healthy. How can he go to a severe stage like this? So over a period of time, we were able to convince the family by daily discussions. Sometimes, showing them the X-rays or progress that probably this is not something which is going to improve. And it took a sort of time, maybe multiple meetings. And I would again stress that the joint meeting is something which, we always have to do, because when it comes from more than one person in the same time and the same opinion, probably that is where the family is more towards accepting it than one person telling. And again, if it's a 3 different meetings, there could be 3 different opinions or directions, which may again confuse the family. So because the family, they're not expert in medical field. They try to have always some doubts because they hear say from the media, from the neighbor, or something like this can happen. So it's always very important that we have a joint meeting. We must have a meeting before we talk to the family. We must have a meeting amongst ourselves that what is the thing which message they are going to give to the family, and then call the family meeting. So that is the key to have a successful meeting.
Thank you, Dr. Vishal. I think we have one more question. How did you deal with the denial of the family of the young woman with 2 kids? can I direct this question towards Dr. Pankaj Singhai? We have had this case. So how was your experience when you were discussing with these family members?
Yeah, so this is a common problem about denial, especially when patient is quite young and was completely asymptomatic earlier. Two important things. One is about the joint family meeting. So whenever we all sit together and conveying a single message to the family members, that help everyone, even the family members, that they don't get different type of messages. So even for family, if we say like there is a 2% improvement in saturations and all, this can give them a false hope. So if there are different messages that goes to family members, that may bring denial. Another thing was the continuity about the serial family meetings over the time. So we were conveying the same messages. Also, we were giving good support, the psychological support to family members. And I think that helped to deal with the denial, because we all know denial is a coping mechanism, but it need to be dealt with more sensitivity and empathy. So having a continued family meetings, delivering the same messages, and providing a good support may help to deal with denial in this case.
Thank you, Dr.
Thank you, Dr. Pankaj. This was a very wonderful session. We all have, from last 2.5 years, we have been dealing with this pandemic of COVID. And there was very challenging time, both managing inside the patient and outside dealing with the family members. Palliative care is a very important aspect that has been taken care of in this particular pandemic. And it was a great support both for the patient, their families, and for the mainstream clinicians also. So with this, I close this session and congratulate you all for this wonderful deliberations. Thank you all.
Thank you.
Thank you very much, sir. Thank you very much, Ankit Bansal, sir, Dr. Sudhir Bhandari, sir, for graciously taking out the time of their busy schedule for this meeting. And thank you all the esteemed chairpersons, all the speakers. It was a very informative, very brilliant discussion, I would say, and the most important discussion. And thank you very much for being a part of it.
Thank you.
Thank you so much. Thank you.